Hi, this is Dr. Bhargava. I have several interesting cases to share with you in this short video. Here's our first patient. They were evaluated with FDG PET-CT for a lung nodule. The nodule is not FDG avid, so I'm not showing that. Instead, there was an incidental finding which we see on this rotating image, a focus of hypermetabolism in the left lung. And this focus on the CT corresponds to pneumonia, with these abnormal air spaces suggesting necrotizing pneumonia. And so this patient was treated with antibiotics and they came back for a follow-up FDG PET-CT a few weeks later. And these images on the right are from the follow-up whole body FDG PET-CT scan showing that the pneumonia has responded to treatment and the focus of hypermetabolism is smaller, and so is the consolidation. And so this is a great example of necrotizing pneumonia seen incidentally on FDG PET-CT and responding to antibiotic treatment. These are two related articles. One of them is an old case report showing FDG uptake in pneumonia, and the other one is on differentiating benign and malignant pulmonary lesions with FDG PET. This is our next patient. They underwent a PSMA PET-CT to look for recurrent prostate cancer. Here's the rotating image. We do not see any focal uptake to suggest recurrent prostate cancer, which is PSMA avid, but we do see a large mass arising from the right kidney. This mass is exophytic and shows heterogeneous, mild to moderately severe or intense PSMA uptake. Here is the mass on the low-dose CT. And this mass shows peripheral patchy uptake of PSMA and central necrosis. And so something like this should be described as a renal cell carcinoma until proven otherwise. And the PSMA uptake in this lesion is because of neovascularization in a renal cell carcinoma. This is a good article on PSMA targeted PET in solid tumors other than prostate cancers. This is our next patient, and they were also evaluated with FDG PET-CT for a lung nodule. The nodule is not FDG avid, and so I'm not showing that. The rotating image does show an incidental focus of hypermetabolism in the left adrenal, and this focus on the axial image corresponds to this 4 centimeter low attenuation or density mass in the left adrenal, and it shows focal hypermetabolism. SUV max was 5.0, and the attenuation in this mass is lower than 10 Hounsfield units. It was minus 2.5, and so the specificity of calling a adrenal nodular mass an adenoma or a benign adenoma is very high when their attenuation on a non-contrast enhanced CT is less than 10 Hounsfield units, and that's what was this case. So this was called a benign adenoma, and about 8 years later, patient presents again for a CT scan, and on the follow-up CT scan, we find that the adrenal adenoma is larger, and because this was performed with contrast for another indication, we do see some contrast enhancement peripherally and some central non-enhancement or necrosis. So adenomas are common tumors arising from the adrenals. They have low attenuation on CT, and they may show incidental focal hypermetabolism on FDG PET, and the specificity for calling it a benign adenoma is very high when a non-contrast enhanced CT shows an attenuation of less than 10 Hounsfield units. This is a case report from 2013 talking about markedly increased FDG uptake in a non-functioning adrenal adenoma mimicking malignancy. This is our next patient. We performed a PSMA PET-CT to stage their prostate cancer, and we will start by looking at the rotating image. The rotating image shows physiologic distribution in the lacrimals, the salivary glands, uptake in the spleen, more intense in the liver, some uptake in both kidneys, and multifocal uptake in retroperitoneal paraaortic lymph nodes extending from the abdomen into the pelvis, and this large focus in the pelvis. So let's go to the cross-sectional images, here we find that right here we have this very large tumor arising from the prostate and invading the surrounding tissues, especially the rectum. We have PSMA avid metastatic disease in both sides of the pelvis. And look at the urinary bladder. There is no excreted PSMA inside the urinary bladder, and that is because both kidneys are showing severe hydronephrosis and hydroureter because of this locally advanced tumor occluding the ureters at the vesico-ureteral junctions, or the UVJs. The other interesting finding here is that there is a metastatic right inguinal lymph node, and this focus right here isn't urine contamination. We find it right here. This is metastatic disease in the epididymis from the prostate cancer. And I have some more images on this patient to share with you. These are MRI images, and they correlate very well with the PSMA PET-CT. So on this axial T2 weighted image, we see urine high T2 signal. We see hydroureter on the left and on the right side, and we see the tumor occluding the UVJ on the right side. Here is the locally advanced tumor that is going beyond the prostate to involve the rectum. At another level, more inferiorly, we find that that's the tumor. And here it's trying to grow into and involve the wall of the urinary bladder. And next we have two set of images, DWI and ADC, at a superior level showing metastatic nodes and the primary tumor with high signal and corresponding low signal on ADC images. Similarly, at a more inferior level, we have the tumor and we have this low signal on ADC consistent with restricted diffusion in this locally advanced prostate cancer. So a good example of locally advanced tumor evaluated by PSMA PET-CT showing bilateral hydronephrosis. And so this patient would be a good candidate for bilateral nephrostomy tubes before the cancer treatment is started. The cancer treatment has to be systemic because the disease is widespread. Also, there's a good correlation between the PSMA PET-CT and the pelvic MR on this patient. This is a related article, very interesting. Here the authors have reported in a case report, complete resolution of locally advanced prostate cancer after therapy with lutetium-177 PSMA. Thank you for watching.